Greetings, everyone, and welcome back to Bright Spots in Healthcare. This is Eric Glazer, and this podcast is produced by Bright Spots Ventures. We bring leaders together from health plans, hospital systems, and other innovative healthcare organizations across the land to share with you proven strategies that drive measurable impact. And through this very podcast and our private executive councils, our private events, and go-to-market strategy work, Bright Spots Ventures helps innovators and companies drive innovations that work in real-world healthcare settings. At our core, we exist to foster trusted relationships between all of you that fuel real progress because we believe, as our regulars know already, the best way to improve healthcare is to find what works, find a bright spot, and clone it. If you've not subscribed to this wonderful podcast, we encourage you to do so, not because of me, but because of all the guests that we are lucky enough to have join us during the show, like the 4 guests you see before you today. They're going to share with you incredible bright spots, just like our past guests have, that will enable you to do your job better. Like I said, our mission is to spotlight what's working and help scale it. In today's episode, we're going to explore how health systems are transforming what happens after the hospital stay, scaling remote specialty care, and closing gaps. Our guests today are, in any particular order, Sean O'Grady, who's the president of acute and ambulatory operations at Endeavor Health out in the greater Chicago area. Dr. Sarah Schenck, she is the executive director of ChristianaCare Center for Virtual Care at ChristianaCare over in the Mid-Atlantic. We'll call it Delaware, right, Sarah? Dr. Matt Sakumoto, he is the medical director at the Connected Care Clinic and the regional chief medical informatics officer at Sutter West Bay of Sutter Health. And last but certainly not least, Tina Nelson, who's the strategic partnership manager and an incredible wealth of information at an organization called TytoCare. So we're going to put their bios in the chat and in the show notes. You'll get a sense of their incredible experience and great expertise. I want to throw out a special shout out to TytoCare, who is our partner for today's episode. They're a long-standing partner of ours, and they are incredible. They were created to help families around the world, not just here in the U.S., who have access issues to primary care to be able to get that access. And they work with health plans to reduce cost of care. And most importantly, for all of you, they work with healthcare systems and providers to improve access to care, improve quality of specialty and primary care through all kinds of unique programs across this country. And you can check them out at TytoCare.com, spelled TytoCare.com. All right. So let's get started. I was thinking about this. I just came back from a short trip to my parents down in Florida. It was not a vacation, but when you fly, you usually don't think about all the different teams working together to get you safely from gate to gate, right? You have your pilots and your flight attendants, but you also have like a really big ground crew. You've got the mechanics, you've got the air traffic control, baggage handlers, gate agents, all of them. And when everything goes smoothly, and sometimes it does, it feels seamless. But when one handoff breaks, right, when something goes wrong, a bag doesn't make it, or maybe a connection's missed, that sucks. Just everything is off. When that happens, you feel it immediately, of course, and it disrupts your entire experience. And I think of healthcare and the handoffs we have in healthcare working in the same way. So when a patient leaves the hospital, there are multiple teams, right? There's the hospitalists, there's the primary care team, there's the specialists, there's the case managers, there's the caregivers at home. They're all trying to stay aligned. And just like your flight, your trip, if one link fails, the whole thing suffers. So follow-ups get delayed, symptoms go unchecked, and sometimes, often, patient ends up right back in the hospital. So what we're seeing now and what today's episode that you're all watching and listening to is all about is how forward-thinking health systems are rewriting the flight plan. They're using remote specialty care, remote primary care, virtual follow-ups, smarter coordination to make those handoffs seamless, and they're reducing readmissions, supporting clinicians, improving the journey from hospital to home. And that's a one-way trip in a lot of these cases. So that's what we have in mind today. So the episode, we're calling it From Hospital to Home, Scaling Remote Specialty Care to Close Gaps and Reduce Readmissions. So there you have it. And let's get started now with Dr. Matt Sakumoto from Sutter. Matt, we're going to put you on the hot seat to begin the show. How is Sutter now leveraging primary and specialty care to make a difference for both the patient experience, my flight experience, but also the overall business?
Yeah, I mean, I think I'm glad I get to lead off. My goal is, I'll be honest, we're not doing anything super innovative, but it's like my goal is for us to do the boring stuff better, right? So one thing that we're kind of focusing on, transitions of care management visits have been around, a billable type of visit since like 2013, actually. So I was looking this up. So it's been around for a while, yet we still have lots of readmissions. And I love your point of what are all the different touch points? Where are the different things where we're lining things up or missing those handoffs? One piece that we realized is when you're trying to do a follow-up visit with a PCP, which is the spirit of that transition to care management visit, that our schedules are so impacted. So it's really hard to get folks in. So that access piece was an issue, particularly in an in-person visit. So what we kind of worked on doing is how do you virtualize that? Large parts of these TCM, transitions of care management visits, are care coordination. It's, did you pick up your meds? Did you get that specialist referral? Did you get that follow-up lab, a few days after you were discharged from the hospital? So, and again, it's coordination, not actually laying hands on the patient. Many times these patients have home health and other things where a nurse is able to do a bit of that exam. So again, kind of quarterbacking basically. So what we did was we really virtualized the TCM visit, both through kind of my clinic, the Connected Care Clinic, where again, we're 80% virtual, 20% in-person clinic. And that just opens up so much access for the patient. One, transportation issues are less of an issue. Two, we get a lot of insight into what's going on in the home as well. So combination of those that have really, really helped. One other piece, again, especially since we're talking about specialty care, is this idea of how do you get into specialists and other things. Here in San Francisco, we have a really high referral center for organ transplant, particularly kind of liver and hepatobiliary services. And so for them, they're coming in from all parts of California. We've actually leveraged not our PCPs, but our hospitalists to handle that TCM visit. Again, really, really helpful because they've seen the patient's course. They kind of know, okay, yeah, these are the different meds, different tests that we need to follow. I'll be honest, even for me as a primary care physician, these are like transplant and immunosuppressive meds that I don't know how to handle. So it's really, I actually prefer and appreciate when our hospitalists are able to look at that and help with that. So again, this once you start to virtualize that transition to care management visit, you can pull in specialists. You can open up this access for patients a lot wider, and we've had a lot of success with that.
Virtualizing it reduces the pull of the transportation issue, gets you quicker to see a specialist as far as access, and also something that folks sometimes forget about is you get to see the patient in their home and get a good sense of what you're dealing with as a provider organization who's trying to keep a patient healthy and out back, or prevent them from coming back. Love it. I'm going to bring in Sean O'Grady. He's the president of Acute and Ambulatory Operations and Endeavor Health. So Sean, I'm going to give you two quick questions. One, just for those of you folks who are unfamiliar with the brand Endeavor Health and are not from the area, just who is Endeavor Health? Look at them very quickly. And then around specialty care, how are you guys approaching what I will call the modern era of specialty care?
Yeah. Thanks, Eric. So Endeavor Health was put together right in the middle of COVID. We went from a 4-hospital system to a 9-hospital system in Chicago. We're academically affiliated with the University of Chicago and cover a pretty wide swath of geography in the suburbs and the north side of the city. And 9 very important community assets across the geography. When we came together with a slightly different commitment as we merged, and that was we need to provide highly subspecialized care in the community that competes and is comparable to what a heavily academic medical center market expects. Our patients throughout Chicagoland expect subspecialized care, and they expect it to be easy and accessible. And so we have set forth on a journey where we are specializing acute care hospitals. And the most visible and longstanding example is 6 years ago, we converted our Skokie Hospital from a full service acute care hospital to dedicated to orthopedics and spine only. and have seen tremendous clinical as well as patient engagement and staff satisfaction improvements from that effort. We do about 12,000 orthopedic and spine surgeries in that platform on an annual basis. Largest hip fracture center in the country now, because we have a subspecialized transfer model to care for those complex patients, and a very robust orthopedic immediate care footprint that is driven by digital triage tools, where we see 250,000 patients a year who are avoiding emergency rooms, and that very unsatisfactory outcome when you sit there for 6 hours and they say, go see an orthopod on Monday. And so we've done that and have our most experience in orthopedics, but we have also done that in cardiovascular care. We're a year and a half into that and seeing the same type of results across the platform.
So the busiest hip fracture facility in the country. So take me through like what we're talking about. Talk to me a little bit about, one, the digital enablement you have within this program to make sure it's humming. And secondly, let's talk about access points, your tentacles across the greater kind of Chicago market, and how are you leveraging the EMR in particular, like Epic, I believe is your EMR, right? So just talk a little bit about how all that works together.
Some of you may have known us as North Shore University Health System, which went big bang early with Epic and went fully electronic. And so we've been a long-standing and refined user of MyChart and all of the digital tools, self-scheduling. We're in the top quartile for patient use of self-scheduling. So Epic has been the enablement tool. We are currently going through the process of getting all of our hospitals on one instance of Epic. So that's our focus in 2026. Because the movement of patients between facilities when you have a subspecialized model is the daily reality. And if you have 3 different patient portals, it's pretty difficult, and for myself included, can make me pretty angry at times. So that's our big effort in 2026, which then offers a lot of opportunity to even put on steroids, for lack of a better metaphor, the digital enablement. But the orthopedics and spine has always been informed by our expertise in Epic. Triage tools, patient outcome questionnaires, self-scheduling, reminders about you haven't followed up on your primary care sports medicine referral, and that ability to do virtual visits when appropriate, post-surgical, or even as an assessment visit.
Got it. Great. I want to shift, not totally shift, but I was about a month ago, ironically, I was in your neck of the woods, Sean, having a group dinner. Also ironic that our guest on today's show from Delaware was at that dinner with me. Someone said to me that it's the combination of digital data and analytics, and they're the key ingredients to like enabling moonshot innovations in virtual care. And so I want to bring in Dr. Sarah Schenck. She's executive director at ChristianaCare. And Sarah, how are you guys investing in virtual care this year? And how do you see that going beyond this year?
Yeah. Thanks, Eric. And thanks so much for having me. It's really a privilege to be here. Just to step back in case people aren't familiar with ChristianaCare, really briefly. So we are academic, community-based nonprofit health system headquartered in Delaware, serving our bordering states in New Jersey, Maryland, and Pennsylvania. And we've been doing virtual and digital care for a couple of decades now in sort of pockets throughout our organization. But in February of 2021, we sort of doubled down and centralized our virtual and digital capabilities to sort of align with our strategy as an organization into a separate business entity. It's actually a separate company called the Center for Virtual Health. And that's where I am now, the executive director. And I promise this is the only time I'm going to read anything, but I do want to read our new sort of mission statement that we came up with together as a team. I work with really a lot of talented and passionate people. I'm really lucky. And so together we came up with this for the center. So our job here is to lead transformation of healthcare delivery by pioneering innovative, virtually enabled care models to expand access, improve outcomes, lower the cost of care, and enhance the overall healthcare experience for all. And of course, when we say all, we mean our patients, but also those delivering the care. So we are sort of a virtual health system, and we're here to support our mother system, ChristianaCare, in innovation, but also we deliver care ourselves. And we have about 15 programs across the continuum. And at the heart of that, really the foundation of our center, and I think the foundation of any health system, is primary care. And I'm also a primary care physician by background, so full disclosure, I may be biased, but I do realize the importance of primary care. It's really foundational for us. And so our primary care practice in the center is virtual. We actually predate the center. So I just told you the center was established in 2021, but this practice started in 2018. And it started as sort of a way to solve a lot of problems for ourselves, right? So we are the largest employer in the state of Delaware, and private employer, and we're self-insured. So we thought, how can we take care of our own better, faster, cheaper? And we thought it started with primary care. And so we created this virtual primary care practice. And how we're investing in it and growing it is really doubling down on the model, which is what I call high frequency, low intensity care. And so most of the care we deliver, in fact, 83% of the care we deliver is done asynchronously. So we're not beholden to the office visit or the video visit. We are really meeting our patients where they are in real time. We do that using a texting platform that's HIPAA compliant and secure, and also emailing and sometimes the telephone. But those are the ways we stay connected to our patients. The other thing I would say is we have a new role that we've created in the Center for Virtual Health, and that's now the most abundant role in the center, and it's called the Patient Digital Ambassador, or the PDA. And the PDA is central to that primary care team. Every patient not only has a PCP, but also has a PDA. And when that patient needs anything, they can just text their PDA, and often do, whether they want to visit or they have a question, maybe there's a side effect they're now experiencing. And so not that the PDA holds all of the answers, but she certainly can activate any member of the team to sort of address those issues. So if it is a side effect issue, she's going to ring up our PharmD, who will then come into the conversation. And I'll just sort of close by saying that, not surprisingly, our patients really like this model. We just switched to Press Ganey to measure our patient experience. So just hot off the press, got back our patient experience scores for this quarter. And I'm really pleased to report of the 23 domains, 20 of them scored in the 99th percentile. The other 3 were 95th percentile and higher. So we're really realizing this, efficiency and convenience for our patients at a lower cost. We've actually learned through our data analytics team that we are saving approximately $50 per member per month when patients are enrolled in our program.
Wow. So big impact, cost-wise, experience-wise, 83% of that stuff is asynchronous. I could already see the play on the bumper sticker. Everyone needs a PDA, a little PDA. That's great. And are you doing this all through your own platform, through the EMR? Like, what's the engine here?
Yeah, so we have a couple of piecemeal platforms. We do use our EMR, which today is Cerner. That's what our portal is through. So our emailing is through that. Then we have a separate platform for the texting.
Great.
Which is integrated.
Awesome. And just before I move on, Matt, this seems a little bit similar, but maybe not exactly the same as what you're doing with your program at Sutter. Or I
have so many follow-up questions for Sarah, but I don't want to dominate this. But yes, very, very similar. We're 80% virtual, and similarly, we're on Epic, so we use my chart primarily for kind of that secure patient messaging piece.
Great. Okay. Yeah, we'll come back. We should poke around on this. I want to bring in Tina Nelson, who is a strategic partnership manager over at TytoCare. But Tina, let's talk about Sanford Health, not necessarily TytoCare. So those of you who don't know who Sanford is, they're an integrated healthcare system in South Dakota. And I know they've been evolving their model to both meet the business and access challenges as far as taking advantage of new technology as well. So what does the new era of virtual care in South Dakota look like?
Yeah, absolutely. So they're certainly thinking about access, but they're also thinking about leakage. Where else would these patients go if they don't have access to care? That could be somewhere else, or it could just be not accessing care at all. And that's particularly important within specialty. They have over 200 Tyto devices, the majority of which are sitting in rural clinics or community centers. And the majority of those are really serving specialty care needs for patients that are commercial, Medicare, Medicaid, you name it. They're using existing staff to do those exams. That includes rooming, as well as doing the physical action of the exam for the remote specialists. Those specialists can be sitting anywhere, and they're really able to see more patients and practice at the top of their license. So really, really effective. They're able to do quality physical exams and perform great visits that both the patient and the specialists are happy with. In fact, Dr. Wallace, who's one of their pulmonologists, has said that he prefers using the Tyto stethoscope to his own. So super effective.
Okay, I want to double click on that and challenge that later on because that's something. But just I want to summarize. So, and how many different like clinics and locations do they have? Number one. Two, is this for all their lines of business?
Yeah, so they're seeing all patients. I don't know the exact number of remote clinics that they have, and they do have Tyto devices spread out within their system. I would say probably at least 100, but don't quote me on that one for sure.
Okay. Great. So one of the things I've been trying to do, and everyone who's listening and who's a regular knows that we're going to send out to everyone just for participating, all the live attendees, we're going to send out a summary of today's episode, the notes that I take, my team takes, a little bit of help from AI, and we're going to send out to everyone sort of a summary of today. So if you want sort of notes, you're not taking good notes, you're on a treadmill right now, whatever, you're going to get all of that. We do ask you in return, as a measure of good faith, if you could kind of give us some feedback on today's episode by completing a survey in about 20 minutes. It'll be emailed to you. We'll also put it in the chat. It's a Survey Monkey. It takes 2 or 3 minutes to complete. It's rather painless, but especially this time of year where we're playing Q1 and Q2 for next year, love getting your input. To that end, one of the things we're trying to also do is make sure we capture some of the great stories told during this episode. So when you think about the story about Sanford and the example that Tina just gave, which is an incredibly cool story about how a rural health system is kind of reshaping how they deliver care, very analogous to what you're hearing from Christiana and Sutter. If you want that case study, I'm going to send it to you because TytoCare did write one up. They also have another one around how Baptist in a different part of the country is scaling remote exams to improve access and reduce costs and improve the patient experience. You have 2 case studies. If you want one or the other or both, happy to send those out to you directly following today's episode. So let us know about that. And again, if you don't know who TytoCare is and why they're so tapped into stories like this, is they enable health systems to deliver remote care through something that they call the Home Smart Clinic. And it combines sort of easy to use, cutting edge FDA cleared technology with an AI powered guidance and diagnostic support that enables either non-clinical providers, or even like your family members to conduct a remote physical exam with a virtual specialist, over an apparatus like we are now, like a Zoom-like kind of technology. It could be anyway, and just takes the virtual visit to the next level. So it's not just a telehealth traditional visit. It's actually a comprehensive exam. She's using TytoCare's technology, and it's helping drive utilization rates up. It's helping improve the clinical care that a provider is able to provide. And some of the numbers I could throw out, they're diverting ED visits by an average of almost 11%, and they have an NPS score of well over 80%. So just a really good way of combining technology with engagement to provide a different patient or consumer experience. And oh, by the way, a different provider experience. So if you want to learn more about them, you could check them out at TytoCare.com. Or if you want an introduction to Tina or anyone on the team, I'm happy to make that for you guys personally. Okay, so Sean, I want to come back to you in Chicago. We started talking about your approach to ambulatory like COEs, and I wanted to get a sense from you as the leader of your ambulatory care operations, like what helped inspire this kind of strategy with all of your hospitals that make up your system?
Yeah, thanks, Eric. So when I was 29, my dad was 59 and diagnosed with a glioblastoma. And I think you all know that diagnosis is incredibly life-changing at a fast pace for a family. And at the time of diagnosis, we made a really important decision to get his care at Memorial Sloan Kettering, since I grew up on Long Island. The effectiveness of that subspecialized model impacted me and my family so significantly that I left that really difficult experience feeling very inspired about how people doing the same thing over and over again and loving it and doing it so effectively really changes lives and is proven to have better outcomes. Contrast that, 3 years later, my mom was diagnosed with lung cancer and chose her provider based upon literally where it was easy to park. And she might have been 4'10", but I could not fight her on any of her decisions because she was strong-willed. That decision went exactly in the opposite direction. A general surgeon, wasn't adept at lung surgery, multiple readmissions, a really difficult 3 years of care that showed me how people get lost in systems. And so those two experiences, so contrasting, informed my desire to bring as much subspecialized care as I could in my career to people and families like us to have more of an experience like we did with my dad. And so that personal inspiration, as well as the reality of looking at our industry where community hospitals doing a lot of things, very low volumes, we know what those outcomes look like, right? And so the pathway forward to greater quality and efficiency isn't about pushing that model further. It's about actually the opposite. It's subspecializing and getting teams of people together who feel passionate and are highly skilled and love coming in every day to do the same thing, because we know they get better every time they do it. And so that's what's inspired me to do it. Also very fortunate to work for a system enabled by Epic so early in its availability. And so we could seamlessly move patients amongst hospitals in ways that others couldn't. And so patients do view at least our 4 North Shore hospitals as one location in 4 different geographies. And so that's unique. I know not everybody has that, but we're going to scale that across all 9 and a much wider geography to make sure that that experience can be replicated and result in the outcomes I mentioned that were so impactful for me and my family.
Wow. So thank you for sharing that. You got into it a little bit, but how do you operationalize such a remote sort of specialty care model in a way that takes advantage of the technology, but also enables you to scale? Like, could you get into sort of what the model, kind of the operating model kind of looks like?
Yeah. So what I learned early on is you got to have aligned incentives. And so if you have hospital presidents or, CMOs at hospitals that are competing with one another for orthopedic cases, nobody's ever going to agree that it's a good idea to go to a subspecialized model. So the first critical step that I did with my leadership team is incentives are aligned around the whole, not the parts, right? That is critical because I've seen too many examples where the fight for I want to keep what I have inhibits us doing the right thing. The second is you got to bring people on board who are passionate and believe in subspecialization. It's a rocky road going from a general model to a subspecialized model, but 6 years in, it's showing everything we hoped and more from all the key measures: quality, growth, consumer engagement. And you got to let the ecosystem self-govern, right? The Orthopedic and Spine Hospital is a totally different entity than the Cardiovascular Institute. What's important to them, how they work, how they wake up, how they want to do things, they have to have the autonomy to do that in the boundaries of our standardization imperative, but you can't make everything look the same. And then finally, integrating medical education and research across the platform has been a key imperative for us and has advanced our impact in outcomes research. And finally, genomics is one of our significant strengths, and that is a key underpinning for all of our subspecialization efforts and goes all the way into primary care. So as my colleagues know, most institutions are doing high-end genotyping for cancer and other diseases. We actually are using polygenic risk scores in primary care to drive prevention and drive life planning that starts with a digital family history and then gets more and more refined depending upon that outcome. So that's another example where the wide funnel using digital, using primary care is imperative to get to the subspecialized model and get the right patients to the right place at the right time.
Wow. Okay. So you just gave me a blueprint. It's one of my favorite questions to ask. Listeners know. So let me see if I could summarize that. So align incentives so the payment models have to work. An ecosystem of self-governance to settle any kind of conflict. Research models integrated into the operating model, which probably is something that improves the provider experience. And genomics based in primary care. So one of the things I know we talked about, and tell me if this was implied or I missed this, but as a staffing strategy for your providers specifically, getting those like-minded folks that believe in the mission of specialty care in this way is important too, right? So did I miss that, or was that implied?
That was kind of like hire for the passion of subspecialization, because before we did this, I would go to the operating room meetings at all the hospitals. The surgeons would complain that person did eyes yesterday, and now you're asking them to do hips and it takes so long to get the room set up. And the person doing the eyes and the hips was like, I don't like to do eyes. I only like to do hips. So it was this confluence of people saying, I want to do something repeatedly and do it well. And so that has become a magnet for attracting people who believe in that model of care, both providers and support staff. SPD is one of the hardest groups to retain and recruit, and they're the most important for safe surgical care. They prefer to work where the trays are the same and they know that the supplies and the equipment they're working with are consistent. So that's been a key part of our recruitment and retention strategy because that passion informs the walls and oozes through the culture and the electronic platform when people care so much about that part of the work they do.
Great. Love that. So I want to bring back in Tina. I mentioned that, Tina Nelson, they work with TytoCare works with a lot of different health systems across the country to address challenges. From your perspective, Tina, and I want to, you mentioned Dr. Wallace, right? Was it Dr. Wallace?
Yeah.
I think James Wallace, right? So
yeah.
From your perspective, how does this approach of combining technology and providers impact the patient experience? And going back to Dr. Wallace, I guess, talk to me a little bit about sort of his experience a little bit more, and then I'm going to eventually peel back the onion on the stethoscope claim, but talk about what's going on with Dr. Wallace and how he looks at sort of combining tech and providers and everything to do with specialty care.
Yeah, sure. So it's always about the patient experience. And you're right, we get these stories all the time and you could pick a million of them. And I've got a ton of them. Dr. Wallace talks about treating asthma from afar, but I think the most impactful one that I heard most recently actually came from Dr. Dave Newman at Stanford. He's the CMO of Virtual Health there. And as part of his job, he's traveled all over North and South Dakota talking to patients. And the story that got me most recently, and this will be on a different podcast here in a couple of weeks, but he talked to this woman in North Dakota who is undergoing breast cancer treatment, and she had been driving hours every month to go to her checkup appointments. She owns a small business, so that meant shutting her business down for the day. Now that they've implemented the virtual specialty program, she literally puts a sign on her door that says, I'll be back in 30 minutes, goes across the street, has her appointment, and comes back over and starts business again. That's absolutely invaluable when you think about the patient experience. Where else could she have gone? And how can you make somebody happier than giving them back a day of their time? So that's the one that really gets me.
That's awesome. And obviously that doesn't happen without the technology that I explained on your behalf earlier to enable providers to get that in real life level experience, albeit virtual. You mentioned the podcast. Is that my friend Joe's show?
It sure is.
So what's the name of the podcast? Because we're going to plug it right now. Do you know the name?
It's called Access Amplified.
Access
and
Amplified. And she's an awesome host, and she's going to be a superstar if she's not already. So that episode's going to drop. It hasn't dropped yet, right? So Access Amplified.
It hasn't. I want to say it's November 11th.
So Jess, why don't we put in the chat and in the show notes a link to that show so we can get folks with that show as well. Before I leave, I want to, because I keep on, talk to me about the stethoscope technology and how in the world a physician can claim that it's as good, if not better, than being actually hands-on in the clinic.
Yeah, sure. So there's the anecdotal evidence for sure. Dr. Wallace says it's just as good as his stethoscope, but I assure you that the TytoCare device and all of its peripherals are FDA approved. So that should be some pretty good backing just there. But with that, we obviously do a number of usability studies. And much like Sarah, I'm going to read this. But in the studies, physicians judged TytoCare's sound and image quality data as significantly clearer and more diagnosable than those from separate devices in the study. And so that includes other digital stethoscopes, regular stethoscopes, et cetera. And that also holds true when it's being used by anybody that's been trained to use it. So very quality technology.
Cool stuff. Cool stuff. You brought up Sarah, so let's bring her in again. So Sarah, self-proclaimed, obviously you're an internist, right? You're a huge, or family medicine, one of the.
No, internal medicine.
Internal medicine, I had it, darn it. And so how are you taking the virtual primary care model that you're so proud of and executing so well, and then expanding that into specialty care? Let's talk about that a little bit.
Yeah, but before we do, Eric, I just want to call out Tina has the best background I think I've ever seen. I'm so jealous of Tina's background. And I also wanted to double down on something Tina just said, which is, if we're using virtual and digital care to just replace bricks and mortar care, we've missed an opportunity. So if I could make a bumper sticker, it would be video visits or so 2020, right? So when we talk about virtual care, I hope we're talking about more than video visits. And we think about ways we can apply virtual and digital care to make it even better. Right. So in the case of a digital stethoscope or a digital otoscope, what I love more about these tools is that patients can see them. It used to be that I would look in a patient's ear and the patient would just have to take me for my word, what I'm saying I'm seeing. But when you have a digital tool, you can actually project it onto the screen and the patient can now see their tympanic membrane and know they do not have an ear infection and they do not need antibiotics, for example, right? So how can we take these tools and make the care even better? And so tying that into specialty care, I'll give you a great example. So at ChristianaCare, we had a concussion clinic, traditional bricks and mortar, people show up. Guess what our no-show rate was in our concussion clinic? It was 50%, right? So 50% of our patients weren't coming because guess why? They couldn't drive. And so we took that clinic, we virtualized it. So yes, we did video visits, so they no longer had to drive, but we did a lot of asynchronous care too. We used our PDAs, we used some automation, we push out surveys, we understand their symptoms, we follow them chronically. So that's a case of actually using digital virtual to make the care better. One more example I'll cite, and that is our long COVID clinic. So we started this in 2021 because the state of Delaware didn't have a long COVID clinic. And we thought that's a problem we should try to solve. So we created in the Center for Virtual Health a COVID recovery clinic. And I'll take 30, 40 seconds to tell you about the model because I'm pretty excited about this model. And I'm hoping we can apply it to other conditions and to other patient populations. It's been awesome as a model. And so the model goes like this. The patient gets referred to our clinic or self-refers, and they reach out to the PDA or the PDA reaches out to them. The PDA tells them about our clinic, make sure that they are on our texting platform, they're on our portal. They do a little bit of an intake, get some background information. They set them up an appointment with the internist who actually in some cases is me. It's where one of the places I still practice clinically. We have that video visit, face to face. It's a long time. It's about 40 minutes of a video visit. We go over their whole history and we do a virtual physical exam. And then we have a roundtable, and this happens once a week. And so we have our specialists come together virtually just like this, and we talk about the patients of the day. And we have cardiology, we have sports medicine, neurology, behavioral health, clinical pharmacology. I call them my dream team. And, like Sean said, these are people that just love what they do, and they're in it just because they're so passionate about patient care. And we love this time together because we're really learning from each other, right? So we're hearing the same case. I'm telling them about the patient's not there, but I'm telling the patient's case. And then together we come up with a care plan for that patient, very personalized. And then the nurse and the PDA on the team, they take that forward. The nurse circles back with the patient after the visit. The PDA coordinates the care. And we stay connected to our patients through texting. Longitudinally, because this is a longitudinal condition. It's not a one and done. And so to date, we've had almost 600 patients in the clinic who we're taking care of, not just in Delaware, but in the other states we serve. And it's a win-win because patients love having this care from all the specialists without having to go and see all the specialists. And the providers and the caregivers, the PDA, the nurse on our team, I'm going to shout out Joanna and Terry, who are the PDA and nurse on our team, are phenomenal. They're a part of the care just as much as I am. And it's been a wonderful model.
I got a couple of follow-ups because that sounds super interesting. As far as the dream team, what's the roster, more or less? Like, give us a sense of this Grand Rounds team.
So we have cardiology, we had pulmonary, pulmonary retired, the pulmonologist retired, and we didn't actually replace him because we're not seeing as many pulmonary issues 4 years out. We have sports medicine. We talk a lot about sort of physical therapy and exercise tolerance, et cetera, behavioral health, clinical pharmacology, neurology, the nurse, the PDA, and the generalist.
And tell me a little bit about how this works on a business level. How do these people get paid? Right? They're all taking notes. How do we mimic this? How are you from the business model? Tell me about that.
Yeah. And if we have time later on in the show, I can tell you how it works for other clinics. For this one, we're still largely fee for service. And the way that we kind of keep our shirts on is we obviously bill for that video visit that I do. We bill to the highest degree because I'm able to bill for time. And then I include the roundtable time that we spend talking about that particular patient because that's all done on the same day. So we actually bill at the very highest level. A lot of the asynchronous care, frankly, we're not getting paid for, but we will bring patients back for follow-up video visits. Either they request it or the team thinks it's needed, and we'll bill for all of the video visits. In terms of the specialist on the dream team, it's an hour a week of their time. It's Tuesdays 12 to 1. It's during their lunchtime. They can get RVU credit for it. And they're there because same thing, right? That Sean said, like they're there because they love it and they get so much professional fulfillment out of being part of this hour and learning from each other.
Wow. Love that. I am going to come back to you on how you're looking at other clinics. That tease you just gave, really well done, because I'm in now. And I'm sure everyone listening's in. I want to, Matt, like bringing you in, because I know some more model, lots of course, so you could kind of jump right in here. Like, let me ask you this: if I was going to drag you out of San Francisco and put you in a market outside of California, just to, I'll pay you well, and you were going to build a similar program, how would you start? Like, what are the key components that you would focus on?
Yeah. And I'll take that. I wanted to rip on a couple of things that Sarah was saying too before talking about like replicating ours. I'd love to replicate hers as well. Really focus on the asynchronous piece, I think, is actually a big part of this. And actually, this will answer some of your question as well. And also what Sean was saying about this idea of aligning incentives. I'll take this video visits or so 2020 to everyone knows the phrase, this meeting could have been an email. A lot of times this video visit could have been a message. And I think once you start to break up the synchronous time that takes up, I'll be honest, patient's time and clinician time and break it into those messaging bits, you can get so much more done. Specific story that actually just came up yesterday for a patient that was discharged from the hospital. Cardiac procedure, post discharge from there, some question around antibiotics. I think in a traditional primary care clinic, I may have like referred them back to cards. Cardiology would have seen them. They would have said, I'm not really sure. Refer them to ID. ID would see them for either an in-person or video visit. And we'd kind of have this like back and forth. In the ability to message, and we're all on the same Epic system, I just Epic message the cardiologist being like, hey, quick question. Do I do this? He goes, I don't know. Ask ID. Okay, great. Ask ID, shot them a message. They got back to me with like, okay, do these things and I'll see them and follow up next week. So we've saved the patient's time, ourselves time, and this is all done in the span of maybe 2.5 hours of just kind of back and forth messaging. So again, that's that power of taking it away from even a video visit, but actually, again, one, aligning incentives, but then two, atomizing things into message-based care coordination. And I think that's sort of, to get back to your question, kind of what would we do to replicate that? It's getting and building that community to be able to do that, right? The trust of like, hey, when I ask a question, I trust that they will respond back to me, and that I'm not asking a dumb question. So it's building trust kind of between the primary care team and the specialists that are all there. Again, all kind of around the patient. So in reflecting on Sarah's model, we basically, rather than having the grand rounds where you have people physically there for an hour, we sort of recreate that sort of on the fly with some of these messaging back and forth and almost group texts, those sorts.
Okay, so I heard a few things. One, I heard asynchronous care. I just heard asynchronous ground round, so I'm going to add that as a separate bullet point. Building a community of specialists. This is in any order, of course. I'll probably out of order for sure. And then what about, are there any sort of things, how about the checklist of things that have to be done? I know when we were prepping for this, we talked about the checklist.
And I think this goes back to what I was saying in the beginning, like just do the boring things better. So that's the thing, like what are the top things that we need to do in this transition of care visit in this very vulnerable time that is going to have the highest impact? And again, none of this is rocket science, but it's really focusing on the medication reconciliation, labs that need either follow-up from, tests that were done in the hospital that need a follow-up, or like retesting to see are they trending in the right direction, and the specialist follow-up. And again, all those things that I listed, you don't need to physically lay hands on the patient. They don't need to come into the clinic. These are all quarterbacking pieces that, I'll be honest, not even myself, it's like our nurse is able to handle a lot of these things. So again, that ability to have a greater portion of the workforce engaged, checking these boxes, but not just checking the box, truly making sure like, what meds are you supposed to be on? And were you able to pick them up at the pharmacy? And if not, what is an easier pharmacy for you to go to, or can we get it delivered to you? So it's not just checking the box; it's actually like delivering, completing the job.
Got it. So meds, lab, especially follow up, all that, the key things that need to be done, the execution list, if you will.
Yeah.
Sweet. Sarah, I'll come back to you now on your T's and like, how are you building? How are some of your other specialty clinics and other operations? What's their business model? Different.
Yeah. I mean, I think, when people ask me like, what's the biggest barrier to digital transformation of healthcare? I say, that's easy. I can tell you the top three. It's payment model, payment model, payment model. And, you get what you pay for. And in healthcare, we pay for the visit, right? We pay for the encounter. And all that in between care that we're talking about today, that asynchronous care is probably, if not as important, maybe even more important, right? And we're just not really paid for that. And so my team is paid to take good care of patients. That's what they're paid to do. And so when we go back to virtual primary care, we have a couple of different payment models there. And so one of them is a direct to employer model. So remember, I told you that we started this for ourselves as an employer, and we felt like, well, gosh, if it's working for us, it's probably going to be appealing to other employers as well. So we do have some contracts with other local employers where we provide care and we get paid a PEPM, per employee per month rate. So we can see that patient 20 times in a month or not at all, but we're staying connected to them. We do have a 421 role. That's an internal role we hold ourselves accountable to, so that quarterly we reach out to them by automation, the PDA text that goes through, are you good? Thumbs up, thumbs down. They can respond to us. They can free text any response, or they could just say, I'm good, stop bothering me. Twice a year, the nurse on the team reaches out to go over their personalized care plan. And once a year, they have a visit with us. So those are all minimums. That's 7 a year. It turns out on average, we do 12. So we're staying connected to them, but we're not paid for those touches. We're paid to take care of them. A couple other models for VPC, for virtual primary care. We partnered with our largest commercial payer. And so they actually pay us for their members a PMPM. So same model, we're getting that monthly. And then we have a direct-to-consumer line now for patients who might not have the right insurance or are not employed with an employer that has our service. So they can actually pay a monthly subscription rate to be in the practice, and they pay for this type of access and convenience and outcomes.
Great. Matt, anyone want to jump in there? I know I hog the mic a lot, so at least the question is, I saw you guys nodding, so.
I mean, for me, it's that alignment incentive thing. And that's really, even for fee-for-service video visit stuff, it's like the true value comes once you have like some sort of either risk-based, value-based, or PMPM modality. Virtual care video visits are really hard to do in the fee-for-service landscape.
Matt, looking at the future, like how are you thinking about the future of remote and hybrid care? And like when you think about the future state at Sutter and what you're doing, what are you looking to do 2 to 3 years down the road, or even sooner?
Yeah, I mean, I think it's scaling it. It's again like Sutter's kind of one of those one name but multiple different regions. So like San Francisco is sort of my domain and area that I get to play in. But it's replication, kind of seeing like, does this work in the Sacramento region, or kind of going down as far into Southern California. So that's sort of, and it's healthcare. At the end of the day, healthcare is local. So even if you're virtualizing things, understanding where to send patients, even to get a blood draw, helping shape that path requires some level of local knowledge. So it's kind of having virtual access, but also tailoring that to the local geography.
What about for you guys, Sean? Where are you going next in the future?
I think with a common instance of Epic, it unleashes a lot of or it reduces a lot of inefficiency and also friction for our customers. Consistent with what I've heard from Matt and Sarah, segmentation is the pathway forward, right? We have to get more dollars out of people's wallets directly for services that are actually enhancing their experience. And we are on the precipice, I think, of being able to commoditize services that people find important, like, can I reach someone when I'm out of town and forgot my prescription, and they can get it called in immediately so that I don't go without my drugs, right? What's that worth per month for someone? And so I think that's what we're all doing, because the government isn't coming in to save any of us, that's for sure. And our third-party payers just use robots to not pay us. So we've got to figure out how to use all of these tools to get direct dollars from our customers because they see the value.
So, and to summarize for you guys, MSK proven, cardiovascular proven, and you're going into
Neurosciences and cancer.
Got it. And those are coming soon.
Yep, neurosciences is and they're both further along with different nuances, but cardiovascular is launched and volumes are up 24% year over year. So clearly, the efficiency is doing something.
Let me ask all of you, but I'll start with Matt. Like, what about chronic care management programming and billing to help pay for some of this asynchronous work? And that comes from an audience member, so I'm stealing.
Yeah. No, I like it. I answered it in the chat, but also happy to answer that live. I think, so we're there, for those that aren't aware, there are CCM, chronic care management codes, also APCM, advanced primary care management codes, mostly Medicare based, I think, but that does theoretically pay for the asynchronous time. We've been exploring it. We actually haven't fully implemented on it yet, mostly because the documentation burden is so high. So it's definitely, we're looking at it closely. We haven't actually launched on it yet.
Sarah?
We're not doing CCM codes. We are doing RPM codes, so remote patient monitoring codes. And actually, that's been working really well for us. We're following patients with hypertension or CHF, and we are billing for that. And we're finally now kind of getting our feet under us. And that, I think, will be at least a break even, if not profitable for us.
And Tina, because there's another question from an audience member, what about the experience implementing programs like this for pediatrics, and how effective has that been, and how important that has been, and where is that happening?
Yeah, so that's happening in a couple of different places. Advocate has a program, Prisma comes to mind as well, where they're using it particularly for complex pediatrics, anytime that it's hard to transport anyone, but particularly a child. And it's not just that child, it's the siblings, et cetera. There's a huge benefit to being able to use the technology. And so, yes, we're seeing that become more popular across the country.
If I make a connection here, we are actually in the pediatric partnership with Advocate. So we, consistent with our subspecialization, came together with our competitor to create a pediatric enterprise where we are using those tools together to make care better for kids. And not all of it's done in our walls. It's done where it's supposed to be done. And that's another example. So I love the connection, Tina.
Yeah, awesome.
Just like we planned it. Tina, can you expand on like going, because Sean just alluded to it, right? So it doesn't always have to happen in a clinic. Talk to me about schools, talk to me about libraries and some of the places you see that programs like this are happening.
Yeah, so really the options are endless. We see a lot of school health programs where school nurses are using the technology to connect in with physicians so that they're able to keep kids in school. That's obviously important for funding purposes. Another huge use case we see is a visiting nurse situation. So bringing the doctors to them. That can be post-surgical. It could be virtual primary care, except they're coming to you. There's a lot of different options, but you have a community health worker or an MA that is going into the home that is usually local and more trusted. So they go in and connect in with a physician. They're able to receive that care that they need, whether it be primary care or specialty care. And you start that continuum, that trust, which is often what you're missing in healthcare in general.
Great stuff. Great stuff. You guys were great. And before everyone takes off, just a reminder to everyone, I will send you some key insights from today. We're going to take some notes, or take all our notes, aggregate them, get them out to you guys. We do ask you the favor, and you saw Jessica Tenzer just threw the survey in the chat, and we'll put it also for you listening asynchronously through your podcast, just to give us your feedback. Take that quick survey, especially it'll help color what programming we put on in Q1. Listening to all of you, and thanks so much for doing this for the last hour. It reminded me of my, this dates way back, but the concept that in business school that I learned, my school was really big into Deming and Edward Deming and total quality management. And that's all based upon sort of what we learned from the Japanese car manufacturers. And I'm thinking about Toyota in particular, but what they did was they studied where things broke down, right? You're talking about a lot of, not so much the end all product per se, but where things were breaking down, and you're creating digital and bricks and mortar and solutions so that the handoffs amongst providers are much smoother, whether it's asynchronous, synchronous, through the Grand Round program, through your PDAs, or whoever you're putting on the front line. And so I'm thinking about Toyota, where they're like, quality fails not in isolation, but in the gaps between people and processes. And that's what this whole conversation was about today. So it just brought me back to business school. And, I think it was Matt that said sort of like, do the boring things better. Like, healthcare's greatest opportunity isn't the new tools, it's redesigning the space, right? Between them. So between hospital and between home, between primary care, between specialty care, between virtual, between in-person, I could go on. So it's when those handoffs are tight and those outcomes improve, and then everything happens good, right? Costs fall. Clinicians can focus on what they do best, caring for people, not chasing the processes. We don't need the government's help. All of that. So I thank you, all of you, for the time you took preparing with me, the time you took in this last hour to provide all these great insights and these great stories. For all of you listening to us, we never take the hour you spend with us for granted. So I hope that you use a lot of the ideas and the insights today and take them back to your organization and apply them right away to make healthcare better for all of us. a shout out on behalf of everyone to Jessica Tenzer, who brought this great group of guests together. We don't get this value without her. So thank you for all that. And just a reminder to everyone, this is your podcast. We produce this show for you. And until next time, this is your Bright Spots in Healthcare podcast. Take care, everyone.